Today, the topic of a discussion would be anatomy of the jugular foramen, and we would be going stepwise. First, starting with the osseous anatomy, and then we'll be taking you forward along the vascular structures and the structures that traverse the jugular foramen. So, beginning, the jugular foramen is actually divided into three compartments. It has two venous compartments and a neural or an intrajugular compartment, through which are three major nerves traverse. So the venous compartments, they actually consist of a larger posterolateral venous channel, which is actually your sigmoid part, which receives the major flow from the sigmoid sinus. And we have a smaller anteromedial venous channel, which is the petrosal part, which receives the drainage of the inferior petrosal sinus. The petrosal part, however, forms a characteristic confluence of the veins by receiving also tributaries from the hypoglossal canal, the petroclavian fissure, and the vertebral venous plexus. This was just an intro so that we will be able to coordinate with the forthcoming slides and the pictures. The intrajugular or the neural part, however, is the one through which the glossopharyngeal, vagus, and accessory nerves they course, and it's located between the two venous channels. So this is the site where the two intrajugular processes of the temporal and the occipital bones they meet, and they're often joined together by sometimes a fibrous septa, or sometimes it could be calcified and result into an osseous bridge as well. What are the major contents? So the contents that actually traverse the jugular foramen, as we discussed earlier, are the sigmoid sinus and its jugular bulb, the inferior petrosal sinus, the meningeal branches of the ascending pharyngeal artery, and the occipital arteries. In the neural structures, we have the glossopharyngeal nerve, the vagus, and accessory nerves with their ganglia, the tympanic branch of the glossopharyngeal nerve, which is also called as the Jacobson's nerve, and the auricular branch of the vagus nerve, which is called the Arnold's nerve, and the cochlear aqueduct. So coming to the osseous anatomy, here we're actually looking at the jugular foramen just from above. So here we can see that this large structure is your foramen magnum. So like we discussed earlier, that the jugular foramen is basically a hiatus between the two bones. So this is your petrous part of the temporal bone, and this is your occipital portion. So this is the squamous part of the occipital bone. This is the condylar portion. So this is the hiatus that we're talking about. So when you look at from above, just above, so you don't really clearly identify, because the dome of the petrous part actually overhangs the foramen, and you're not really able to see it as a clear-cut foramen, like you can see here above the foramen lacerum, how clear it is, and the foramen ovale on the contralateral side. Also, we have the sigmoid groove or the sigmoid sulcus, along which the sigmoid sinus basically runs and then takes a sharp turn anteriorly forwards, through which it enters into the jugular foramen itself and exits to join into and to form the internal jugular vein. Now, this is another view of the same bony anatomy that we can appreciate, but this is basically when you're looking from posterior backward. So here we can actually appreciate the anatomical structure and the anatomical outlines of the jugular foramen. So this was the anteromedial smaller part, like we were discussing initially, which was the petrous part, and this is the part through which the inferior petrosal sinus traverses. And this is your posterolateral part, which is usually the larger part, and this is the portion from which the sigmoid sinus traverses. Coming to other relationships, we can appreciate hypoglossal canal, which actually lies further medial to the jugular foramen, and obviously slightly below, around 5.5 mm, in some cases 8 mm below. We can also see the junction, which we can appreciate between the two bones. So this is your petroclavian fissure. This is the junction between the clivus bone and the petrous part of the temporal bone. So this is your temporal bone. This is your portion of the occipital bone, and this is the hiatus, which is called as the jugular foramen between the two bones. We can also see the cochlear duct opening just above and just anterior to the petrosal part of the jugular foramen. Also, we were talking, like in the initial slide, I discussed that we have basically three compartments of the jugular foramen itself, the two venous channels and an intermediate neural compartment, through which are three major nerves, last three cranial nerves actually traverse. So that is basically formed by the division of the intrajugular processes. So the temporal bone has its own intrajugular process. So this is the jugular process of the temporal bone, and we have a intrajugular process arising similarly from the occipital bone as well. Often it does happen that the two processes actually join together either via a fibrous band or a septa, and sometimes it could be ossified as well, and that can result in a bony septum that would be actually dividing the foramen into um, two other foramina basically. So we can also appreciate the opening of the internal acoustic meatus here in the same slide and same picture. Also the vestibular aqueduct, which can be seen on the posterior part of the temporal bone. This is the posterior aspect of the temporal bone and just lying superolateral to the sigmoid portion of the jugular foramen. These are the occipital condyles which are located inferiorly. This is the squamous part of the occipital bone. Then when you're looking at the jugular foramen further from inferior, so we can again appreciate that this is the foramina itself, and we can see that the carotid canal, which just lies anterior to the jugular foramen, is actually separated just by a single bony ridge, and this is the area from which we have the exit of the internal carotid artery. These are the occipital condyles, which we can appreciate well now because we're actually viewing now the jugular foramen right from the inferior. Previously, we were actually looking at from superior posterior backwards. This is the posterior condylar foramen through which the imaginary vein usually traverses. Then lateral to the jugular foramen, we can actually appreciate the stylomastoid foramen. This is the area where from the facial nerve usually exits. And then another diagram, which is actually going to be further explaining the osseous anatomy of the jugular foramen. This is now directed anterior backwards. And we can see again here the smaller petrous part, which is lying anteromedially, that is directed anteromedially. And then we have the sigmoid portion, which is directed posterolaterally, and this is usually larger. However, it is also said that the jugular foramen on the right side is usually comparatively larger as compared to the one that is present on the left side. Similarly, this is the petroclavial fissure, which is the junction between the petrous part of the temporal bone and the clavis bone. Here, we can appreciate the carotid canal here as well, through which internal carotid traverses. Then we have a bony ridge that is actually separating the jugular foramen and the carotid canal. However, once they go down in the neck, the structures tend to lie medial to lateral. Then now this is basically a further magnified view of the jugular foramen itself, but the structure now what happens is the two bones have been forced open to actually show you the structures and the anatomy that I was discussing here earlier. So this is the superosterolateral part, the widened part through which the sigmoid sinus traverses. This is the anteromedial part, which is directed medially. So this is the petrous part through which the inferior petrosal sinus exits. This is the squamous portion of the occipital bone, like we were talking about. This is the petrous part of the temporal bone. This is the intrajugular process of the temporal bone. And this is the occipital bone actually has an intrajugular process, which is usually smaller as compared to the process of the temporal bone. This is a hammered process, which is often present on the occipital bone, but it sometimes has a bony prominence of the jugular bulb itself. So the sutures have been opened here. Sometimes what happens is, like I discussed earlier, that the two processes, they are joined together, and basically medial to it actually lies your neural component through which the nerves traverses, and the sigmoid tends to lie posteriorly, and the petrosal sinus, inferior petrosal sinus, tends to assume an anterior portion or an anterior anatomy. Another view, this would be explaining the concept of the intrajugular ridge. Why is that important? Because what happens is that our three nerves that we're talking about here, that's the glossopharyngeal, accessory, and the vagus nerve, they tend to traverse down and they tend to pierce the dura basically along the medial edge of the intrajugular ridge. So this is the intrajugular process that is arising from the temporal bone itself, and we can see that there's a smaller ridge-like structure that is further descending down from itself. Wait, sorry. So this is the posterior aspect. This is your sigmoid part. Anteriorly is your petrous part, and this is the medial margin along which the glossopharyngeal nerve, the accessory, and the vagus are going to traverse. What happens is that the glossopharyngeal tends to assume and courses along the medial margin of the intrajugular ridge. However, the two other nerves, that is your vagus and accessory, they start from here, but then they tend to assume a more lateral position and while they're exiting the jugular foramen. This is the internal acoustic meatus. Here we can appreciate the vestibular aqueduct, like we discussed earlier, which would be the endolymphatic sac actually opens it via the vestibular aqueduct into the vestibule. And this is your opening as the cochlear aqueduct, which is just lying, like we discussed, on anterior to the petrous part and just superior. Now this is the lateral view. So the lateral view, like we were talking about the stylomastoid foramen and all the orientation. So we can see here that this is your mandibular condyle, and once you remove the mandibular condyle, so it's actually residing in the mandibular fossa. This is the laterally oriented styloid process. This is the jugular foramen that we can see. So the jugular foramen is actually bounded laterally by the styloid process. We can here appreciate the transverse process of the C1. The vertebral artery tends to course posterior to it and forms a posterior limitations in order to access the jugular foramen. Here we can appreciate the squamous part of the occipital bone. This is the mastoid itself. This is the tympanic bone, which is a tympanic part of the temporal bone, and this would be the hiatus of the jugular foramen. Then inferiorly, like we were discussing on earlier, that the carotid canal lies anterior to the jugular foramen, and between the two is a bony ridge, which is actually separating the two structures, that is jugular foramen inferiorly and carotid canal anteriorly. Also, like we were discussing, that we have the two important branches, that is the tympanic branch of the cranial nerve 9 and the auricular branch of the cranial nerve 10. So we can see that the jugular foramen's interior boundary has an opening of the tympanic calculus via which the tympanic branch of the cranial nerve 9 exits, and we have a groove on the lateral aspect basically for the cranial nerve 10th branch, that is your auricular branch cranial nerve 10, and this is going to exit via the mastoid canaliculus, and it's going to be joining the mastoid portion. Then discussing the adjacent bony structures. So we know that the petrosal part of the foramen is usually located approximately 5 mm below the porous part of the internal canal and 5 mm above the intracranial orifice of the hypoglossal. The jugular tubercle itself is a rounded prominence which is usually located at the junction of the basal and the condylar parts of the occipital bone, and it's usually situated medial to the medial edge of the jugular foramen. The occipital condyle itself is located along the lateral margin of the anterior half of the jugular foramen in the area below and medial to the jugular foramen. The intracranial end of the hypoglossal canal is situated below the jugular tubercle, around 5 mm medial to the petrosal part of the jugular foramen, and several millimeters down the lower part of the petroclival fissure. So now coming with the vascular anatomy. Now here we can see, previously we were discussing all the bones. Why was that important? Because this would, however, then tell you once we have all the pictures and the orientation that we were previously talking about. So now we have all those venous and the neural structures now present in these pictures. Now taking you slightly backwards, this is the area of interest that has been highlighted, and now this is the area of interest that has been highlighted in the forthcoming slide. So here. Now here we can appreciate that this is that we were talking about initially, that we have a sigmoid groove or the sigmoid sulcus, which is actually coursing and present on the squamous part of the occipital bone. So this is the area where the sigmoid sinus we can see is running, and we were talking about an anterior sharp bend that it takes forward to traverse through the superior posterior lateral part of the jugular foramen. So here we can appreciate the jugular bulb of the sigmoid sinus. We were initially talking about the endolymphatic sac being opening into the vestibular aqueduct and getting an entry into the vestibule. So here we can appreciate that opening, which is again located just above superior laterally on the temporal bone. Then we can appreciate that this is the intrajugular process of the temporal bone. The three nerves can be appreciated here from anterior to posterior. We have the cranial nerve 9th, cranial nerve 10th, and cranial nerve 11th. So this is where they're actually piercing the dura itself. So this is the intrajugular process, and then there is a ridge, intrajugular ridge that we were talking about, slightly arising basically from the temporal bone itself, but slightly directed inferiorly. So we were talking that the 9th cranial nerve actually traverses along the medial margin of the internal jugular ridge. So this is the 9th cranial nerve, which will be actually traversing and coursing along the internal jugular ridge. However, the 10th and the 11th cranial nerve also tend to arise once they're piercing the dura through the medial margin, but then they tend to assume a more lateral course, like we can appreciate here. Again, a magnified view. We can appreciate the opening of the auricular branch of the 10th cranial nerve, like we were talking, on the lateral margin of the jugular foramen. Then we can appreciate that the superior ganglion of the 10th cranial nerve, which is the widened portion of the nerve itself, the intrajugular process of the temporal bone, jugular fossa, which is usually a bony landmark, which is housing the sigmoid, the jugular bulb itself. Here it was exposed in order to identify the jugular bulb. Here again, we have the osseous covering present here. And we can appreciate the cranial nerve 9 going across. You have the cranial nerve 10 that's going across, and the cranial nerve 11th, which is actually reversing down. So here now in this picture, what happens that the nerves have been pushed down in order to give again that concept of the osseous bridge. So this is your occipital part of the bone, occipital portion and the occipital boundary of the jugular foramen. This is your temporal part of the bone, of the jugular foramen itself. So intrajugular process of the temporal bone, the jugular fossa, which was actually protecting your jugular bulb. Then we have the tooth. Now here we can appreciate that osseous bridge, which we were talking about, between the two processes of the two bones. So the temporal intrajugular process and the occipital intrajugular process. So here now this is ossified. Underlying it, basically, we have these. So this is the site of the neural component. The nerves here have been retracted downward in order to show and depict the clear anatomy of and the concept of the osseous bridge. We can also appreciate that the carotid artery that you're traversing down. So if you look, so this is basically your anterior posterior view. This is the carotid artery, the carotid traversing through the carotid canal, the inferior petrosal sinus, which would be exiting through the anterior medial portion. Then we have the posterior lateral portion, like we can see, because this is your jugular fossa, which is protecting the jugular bulb, like we were discussing, that the sigmoid sinus actually runs through a groove, takes a sharp anterior medial turn, and then exits through the jugular foramen itself. Then another view, and here we can actually now appreciate the atlanto-occipital joint as well. So this is your occipital condyles, which are present here. This is your atlanto-occipital joint. Why this is important? This is important for the orientation of the vascular anatomy and majorly the orientation of the vertebral artery. We know that the vertebral artery is actually coming from down below, and it is going to be coursing along the transverse process of the C1, and then it traverses upwards into the base of the skull. So here it is actually going around the transverse process. Again, we have this inferiorly directed hypoglossal canal, like we discussed, that it's lying almost 5.5 to 8 mm downwards, the jugular foramen just on the medial aspect, and this would be how traversing, and through which the 12th cranial nerve would be traversing down. So this, you can appreciate the 12th cranial nerve. However, once they all are exiting, so they tend to assume a single neural compartment. So this is the cranial nerve 9, this is the cranial nerve 10th that we can appreciate as cranial nerve 12th here. Now, coming to the next slide or the picture, this would give you an orientation of the lateral view. So I have this now. Now we have sequential dissections. This would be with the skin and musculature intact, and then we would be retracting few muscles and removing few muscles, and then going further deeper down. So coming to the first picture, now we can appreciate that this is obviously our external auditory meatus. This is the ear we can appreciate, right? So anteriorly directed is your parotid duct and the parotid gland, which just lies anterior here. Here we can appreciate the belly of the sternocleidomastoid, now that is coming from the posterior and then coming to get attached to the clavicular head. Here we can appreciate the auricular nerve, which was actually a branch of the 10th cranial nerve. We can see the 7th cranial nerve branch, which is your facial nerve, relating to the stylomastoid foramen. This is your great superior temporal artery, actually, just running anterior to the tragus. So now, removing the skin, we can appreciate the muscles here now. We have the posterior belly of the digastric. We can appreciate that this is your tympanic bone of the tympanic part of the temporal bone. We can appreciate the superior temporal artery, like we could appreciate here just underlying the skin. Now, after the skin is removed, we can appreciate its subcutaneous orientation. Then we have the 7th cranial nerve, which was the branches of the 7th cranial nerve, which are actually traversing to supply the sensory branches to the face. Then we can appreciate the masseter here. maxillary vein, which is actually going to be a branch of the external carotid artery, and the retromandibular vein itself as well. The submandibular gland directed here. Here we can appreciate the internal jugular vein, which is actually formed by the confluence of the sigmoid. Once inferior pectoral sinus actually drains into it. Then now, since now the muscles have been removed, so we can actually now correlate with the bony anatomy and the vascular structures itself. So this was the condylar fossa, which was actually housing the mandibular condyle. This is the tympanic bone of the temporal tympanic part of the temporal bone. Here we can appreciate the tympanic fissure between the squamous part of the temporal bone and the tympanic part of the temporal bone. Chorda tympani, which is a branch of the seventh cranial nerve. These are the two further deeper muscles which are present. We have levator villi palatini and tensor villi palatini, which are running here. Ascending pharyngeal arising at the branch of the external carotid artery. This is your internal carotid artery exiting from the carotid canal. Then we have here, we can appreciate the internal jugular vein. Now, says this is all that we're actually looking from the lateral aspect. So we know that the carotid canal was lying anteriorly to the jugular foramen. Jugular foramen was oriented posteriorly. So that on the neck, when you see, so basically it is your middlemost portion would be laterally would be your internal carotid, then medial to it would be your internal jugular vein. And if you're looking laterally, so it would be like anteriorly would be your internal carotid artery, and posteriorly would be your internal jugular vein, and in between them would be your neural structures. This is your styloid process, which has been trimmed down. We can appreciate the external carotid artery arising here. This is the 12th cranial nerve. These are the stylopharyngeal, styloglossus, and the stylohyoid muscles, all the muscles that would be supplying the tongue. Then the next view, in the next diagram, which is your picture D. Here further, we can actually appreciate clearly the venous anatomy and the vascular anatomy, sorry, the internal carotid artery. Then we can appreciate that this is your ninth cranial nerve. This is the 10th cranial nerve, ninth cranial nerve supplying the anterior portion through the pharynx and the adjacent structures. This is the external carotid, which was giving off branches like ascending pharyngeal, which was coursing anteriorly above here. And we can appreciate the internal jugular vein, which is rising here. This is the 12th cranial nerve, which is your hypoglossal. And this is the occipital artery, which is again arising as a part of the internal carotid artery. Then another view. Now here we can appreciate basically the this is a further lateral orientation. So this is your mastoid. This is your tympanic parts like we were discussing here. And this is the seventh cranial nerve. This is internal jugular vein, which is directed posteriorly. We can appreciate the C1 transverse process here running, and the vertebral artery actually coursing along it. This is your occipital artery, which is actually coursing along. And we can appreciate that the venous ventral ramus of the C2 vertebral artery here actually is coursing along the C2 exiting and then coming anterior to the C1. These are the levator scapular muscles and the internal carotid artery, which is actually directed anteriorly. Similar diagram with further enhanced views. So here we can appreciate the eustachian tube, which actually tends to open into the tympanic cavity. The connection between the ear itself, the middle ear, and the skull base. You can appreciate that the lingual nerve, external carotid artery, which is actually this is the base of the neck actually, and this is your internal carotid lying laterally, internal carotid lying medially, then the internal jugular vein, which is lying further medial to it, ascending pharyngeal, which is arising as a branch of the internal carotid artery, the seventh cranial nerve, which is actually giving off branches to the facial component, and this is how where it is going to be entering into the jugular foramen from here. So this is basically further we can actually appreciate the inner ear and the components of the ear bones. So we can actually appreciate the supported tympani branch of the facial nerve. This is the posterior auricular canal. Then this is your malleus bone. This is the incus and this promontory of the cochlear aqueduct where the semicircular canals are actually present. This is the jugular bulb, like we were talking, which was the predominant and the dilated portion of the sigmoid sinus itself. Then we can appreciate anteriorly lying internal carotid artery, posteriorly lying jugular foramen, the carotid bridge that was actually separating the internal the carotid canal and the jugular foramen itself. Um, the again the carotid tympani branch, which is actually the seventh facial nerve, giving off branches anteriorly. Here we can appreciate the external carotid branches, which are the meningeal branches, and the occipital artery here. And this is a similar picture showing the same vascular anatomy itself. Okay, so here we can appreciate now the nervous structures or the neural structures that can be present here. So we were talking about basically what happens is that the jugular foramen has two perforations for the entry of the nerves. That is through one hiatus, the glossopharyngeal exits, which is actually running along the medial margin of the intrajugular process of the temporal bone, and through the second hiatus or the meatus, there's the exit of the 10th and the 11th cranial nerve. So this is the dural septum that I'm talking about, and often this again the septum also gets ossified. So this is the jugular foramen. This is the dural fold of the jugular foramen, which is usually thickened towards the temporal part, and this is the meatus through which the glossopharyngeal nerve is exiting, and this is the other meatus through which the cranial nerve 10th and the cranial nerve 11th are exiting. So there are two meati, and then here, this is again the area of the endolymphatic sac, which is basically present in the posterior part of the temporal bone. And this is just directed at the superolateral edge of the foramen. This is the anterior portion from where we can appreciate the labyrinthine artery and the seventh and the eighth cranial nerve. This is above the jugular foramen, the exits. Here, once the dura has been removed, so we can appreciate, like previously we were talking about, that this is the intrajugular process of the temporal bone. This is the portion of the endolymphatic duct. This is the sigmoid sinus, that is its traversing, and the sigmoid sulcus, sigmoid groove, along which it would be exiting here anteriorly. This is the intrajugular septum or the ridge, which is often the junction between the two processes of the adjacent bones. This would be your cranial nerve 9, which is seen coursing along the medial edge and then going laterally. This is the inferior petrosal sinus area, which would be exiting through the anterior medial portion. And then in picture C, we can appreciate here that this was yeah. So here we can see that this is the lateral lesion. This is the cranial nerve 9th and 10th, which are actually exiting lateral. And these are the dilated portion of the superior ganglion of the cranial nerve 10th and the superior ganglion of the cranial nerve 9. These are the dilated portion of the two nerves. The cochlear aqueduct, which is actually present just above the petrosal part of the jugular foramen, anterior to it. And here, like we were discussing, once it's on the margins, so we can appreciate that in the lateral aspect, we have the auricular branch which exits, and through the auricular there was an indentation on the bony structure as well. Then we can appreciate here further laterally that there's an internal carotid artery which is actually traversing via the anteriorly lying carotid canal. This is the occipital condyle, which is actually forming the medial boundary or the medial edge of the jugular foramen, and this is the vertebral artery, like it was coursing through the C1 transverse process and then coming off anteriorly to enter here. This was the joint that we were talking about initially between the occipital condyles and the atlas, which is the first vertebrae. Similar magnified view, cochlear aqueduct lying anterior to the petrous part of the temporal bone. Then we have the jugular tubercle, which was again a prominence over the aspect of lateral aspect of the intrajugular process of the temporal bone. Then the cranial nerve 10th and 9th seen exiting along the medial edge of the intrajugular process, traversing along the medial ridge as well. 10th assuming a more lateral position and joining forwards. This is the dilated portion which is the superior ganglion of the cranial nerve. 9th, the 10th auricular branch which is exiting through the lateral aspect. And yeah. This is a lateral view. Once we would be approaching, like here in the insect, you can see that there are few approaches via which we can actually access the jugular foramen or its content. We have the posterior auricular approach, we have the retrosigmoid approach, we have transcondylar approach. So this is basically why when we would be opening via the retrosigmoid approach. So here is what we encounter. So the insect is basically showing an incision of the retrosigmoid craniotomy. Now, once we open after the scalp and the bony anatomy, now here the cerebellum has been retracted laterally, and we can appreciate the exits of the cranial nerve. So through the dural fold, anteriorly lying dural fold, glossopharyngeal is exiting through the glossopharyngeal meatus. Then there's the dural septum, which is actually dividing the two neural meatus, that is the glossopharyngeal meatus and the vagal meatus. And the vagal meatus, oriented posteriorly, has an exit of the cranial nerve 10th and the cranial nerve 11th, which can be seen. The hypoglossal nerve, which is actually lying and arising from the medially oriented hypoglossal canal, is seen here, but eventually this is seen arising as root tips from the medulla, like we can see. But then when they're further coursing down, so they all assume a single neural canal, and they all join together to form the area. Here, this is a downwards view. We can see that the vertebral artery is actually coursing from down upwards. Also, ICA can be appreciated here. Also, ICA can be appreciated here, which is actually coursing along the 7th cranial nerve, which is the branch of the basilar artery itself. So again, another view, and here we can appreciate now similar anatomy. That this is basically cranial nerve 6, which is your abducens. This is oriented cranial nerve 8, which is more dominant here. Then ICA coursing along the anterior part. Then we can see the cranial nerve 9 that is actually seen arising from the inferior posterior olivary sulcus between the middle and the olives, inferior olives, and we can see that this is oriented laterally. Then we can see the 10th cranial nerve in order of preference, basically in descending order, cranial nerve 9th, 10th, and then we can appreciate the hypoglossal nerve arising as part of multiple rootlets and then traversing downwards. So the two meatus that they were talking about, and this was the jugular fold, dural fold of the jugular foramen, or the lip of the jugular foramen, which was again thickened at the level of the petrous part of the temporal bone, because that is forming a dome over the inferior part or the condylar portion. So this is the septa that is actually separating the two nerves, the glossopharyngeal meatus exiting the glossopharyngeal nerve, which is cranial nerve 9th, and then the 10th and the 11th nerve exiting from the vagal meatus, and the septa that is actually lying in between the two meatus. And this is again a similar picture showing similar anatomy. Thank you.
Thank you, Dr. Afifa, for such a detailed presentation of this complex topic. Dr. Yasir, can you please make Professor Cherian co-host so he can give his expert comments and maybe share his cases as well? Dr. Cherian is co-host now. Your expert comment, Professor Cherian, and if you have cases, maybe.
The first thing first, Salman, I am really proud of the way that your resident is presented. I mean, I was just remembering that the highest quality of presentations that I have seen is definitely from Pakistan. I have seen Hira present. Now I've seen this girl present. It's outstanding. That's all I can say. Now I would try and show you some. See, I've just settled in India, and for the last 1.5 years we had COVID. So I had a jugular foramen lesion. I was trying to just search it out, but yeah. So you have it here. Yeah, but I will show a dissection first. I will show what Afsa was showing. I'm going to show you a dissection of. Do you think Afsa, can you put the anterior part of the petroclival fissure? So a look from anterior. That's exactly what.
Can you put on the image from an intake? Yeah.
Yes, sir.
Bony part. Yes, yes, yes.
Yeah, this one.
Right, absolutely. So one of the things that you must know is that you start from the petroclival fissure. So if you are doing a clavectomy, I'll show you a case where we did clavectomy. But if you are doing anything lateral to the clivus, there is a petroclival fissure. And the petroclival fissure, interestingly, ends in the jugular foramen. Can you appreciate that part? So you have an inferior petrosal sinus. The inferior petrosal sinus actually drains into the, yes, that is what, exactly. Whoever is pointing it there, that is exactly what they are showing. The petroclival fissure ends in the carotid, in the jugular foramen. Okay. Now we are going to show that. We're going to take and above that petroclival fissure, you must understand that the carotid is coursing. The C6 carotid is coursing and coming to the foramen lacerum. So if you drill off the sublaceral part, yes, that is about it. I cannot show it where it is, but just above the petroclival fissure, just above that small bit of bone, if you remove, you are laying bare the C6 petrous carotid, and then you can see the jugular foramen. This is exactly what I'm going to show you. Shall I share my screen now?
Dr. Afifa, can you stop sharing so Professor Charin can share his screen?
Yes, now I am sharing. Right. So can you see this dissection image? It's a pretty bad image, but can you see it?
Yes, we can.
So obviously those are the optic nerves, and this is the C3 segment, the vertical segment. That is the C2 segment, that is going intradural. So that is a lateral opticocarotid recess where the anterior clinoid process would have been. This is the medial opticocarotid recess. Then you have the C4, horizontal cavernous carotid. Then you have C5, that is the paraclival carotid, right? And this is the foramen lacera. And from here, you can see the petroclival fissure is going down. Okay, so that is a clivus. That is a clivus. Okay, so the petroclival fissure, if you see, the petroclival fissure is way anterior. So the petroclival fissure will be going down and reaching. So that is exactly what I'm going to show you now. So that part is not important. Now we are going down. That's the C3 vertical carotid. And then we'll go to the paraclival carotid. This is the C4 horizontal intracavernous carotid. And then the paraclival carotid, that is the petrous carotid coming there, down there. I have drilled this bone completely, the sublaceral bone, the sublaceral carotid bone I have drilled, and that is the jugular foramen. Okay, that's the jugular foramen through the nose. So that's your carotid, C7 parapharyngeal carotid there. And let me just pose it for you a second. Yeah. So you have carotid there, you have internal jugular vein there, and that is your jugular foramen. Okay. So this is reaching the jugular foramen through the nose. So I can also show you a case that we recently did, but this is not reaching there obviously, but I do this. So you can see a case. This is a case where, we recently did this. Patient had 9th, 10th, 11th palsy. Patient had quadriparesis. And you can see the basilar is completely displaced to the right. And then you have the brainstem completely around it. So while it comes up, you can see the axis. No, I want to show you yeah. So now you see it's in the pons, okay, and going up to the pontomedullary junction. So up till here, so you can see the basilar is right here, okay. The basilar is right here. Give me a second, guys. Hello? Sumit, I am talking in a meeting now. I'll just call you in 5 minutes. Right. 5 minutes, I'll call you back. Right. So you can see this tumor. And then now you will have to see now, that's the fun part of it. So you can see these are the tracks. And there is no way you can approach this tumor from anywhere except right in the middle. Okay. If you even approach it from, of course, subtemporal Kawase, extended Kawase, I could have tried, but then this part you would not get before retracting this part, and retracting such a thin brainstem would be disastrous. Somebody tried to get it from a CP angle, so they could not even get a biopsy of it. So, I mean, we didn't want to have that fate. So we measured this distance that was about 13.5 centimeter. So we went ahead, and of course, we are now in the nasal. We are in the nasal phase, drilling all the sella out. Of course, we have to expose everything. Now, my ENT partner had exposed all that. Now we are going the paraclaval carotid. Behind the paraclaval carotid is the Gulfar segment of the cavernous sinus, where the inferior petrosal, superior petrosal, and the posterior segment of the cavernous sinus will join. So we are drilling it out now. And then now I have opened the dura. You can see I am under very high zoom. I have opened the dura, and then you will see immediately that I am on the vertebrals. So I have to clival plexus, that is a vertebra. That's a vertebral artery. And I have to take up this dura and then bipolar. There is no way I can bipolar it crossing the dura sheet. If I bipolar, the perforators will be fried. So the tumor is pushing all the perforators and the basilar right next to me, right next to the dura. So I have to go hook the dura up and then bipolar, and then, because if you cut the clival dura, there will be severe bleeding. So you have to hook this dura up with a upturned bipolar, and you can keep on taking this tumor out gently through the segments that you get between the sixth nerve, between the perforators, the sixth nerve, the basilar perforators. You will see them now. Then keeping on taking out the tumor. Keeping on taking out the tumor. That is the sixth nerve. You can see, I will show you the sixth nerve. That is the sixth nerve. That is the sixth nerve. And basilar is here. That's a vertebral. There is one perforator here, one perforator here. We are going in through this, and these millimeters of space is where you can take out the tumor. So that's the sixth nerve. So you cannot bipolar here. That is another big problem. This is brainstem. So it bleeds. You have to just keep on dealing with water. That is all, irrigation. Continuous. You have to have underwater surgery. Here, if you bipolar, it is going to be not very pleasant for you. That is one perforator. Can you see? That is the basilar perforator. This is the basilar artery. I'm into the brainstem right now. So that's the basilar perforator. And you know, unfortunately, the Escalab guys lost this recording. I wanted to murder them, but one of the fellows who was standing there, from his phone, we had to get this. So this is one perforator. Just before that, you can see, this is one perforator, and you will see the next perforator here. Yeah, this is one perforator. This is the vertebral. Sixth nerve is here. So this is the area that I have to go through and take the tumor out. So we went ahead and did a complete resection of the tumor. So you can see the tumors here. You can see the blood lining, everything here. Well, we've been able to do this because we had this contraption. This is something that we designed. This is an endoscopic holder, robotic endoscopic holder. I used to have the pneumatic holder before, but the thing is, this one is anti-gravity. So, which I touch it, it's floating, just like a best microscope. And, it costs 1/10 of what is a robotic holder. It's an industrial robot with very, very high safety standards. So we designed it and we made it. And, for about $40,000, we have it. I'm just showing to Charlie Teo, who came and to our theater. So I was showing him this. So we, with this thing, we are able to see, my ENT partner is able to hold the robot. I mean, the robot is holding the scope, and you can easily do every dissection. You can bring it down, you can bring it up. Only thing we don't have is the focus and zoom. Too much focus and zoom is not available with the scopes, endoscopes. So this is the anatomy that we were talking about. So you can see that is the vertebrals, that's the basilar, and that is the tumor. I mean, let me. Yeah, so that is the basilar, and this is the corridor through which you have to take out the tumor. So you have to go transmaxillary, transpterygoid on one side, take the Gulfard segment, this is the Gulfard segment of the cavernous sinus that you have to open, and that is how you can take out. Then you have to open the claval dura, and then you have to take out this tumor. That's how we went ahead. Also, for the last 1 year or so, we have started operating with the exoscope. This gives us a lot of, I would tell for the young neurosurgeons, the exoscope is the future. I have a Kinevo which is lying unused right now. My junior consultants are using it right now. So that's this is the exoscope. The kind of possibilities, surgical possibilities with it is immense. So we just recently did a giant cavernous aneurysm. So first did a bypass, and then after that we trapped off the cavernous aneurysm, completely done with the exoscope. We did a petroclaval, which complete. This is the ST harvest. So another ST harvest some time back. So well, before I stop, I would like to say I would be very grateful if you can send the recording of this talk, this lady's talk, to me so that I can show it to my residents. And I'm so happy to connect again with Salman and his team, and the quality of things, I must say, is very, very high. And I'll be more than happy from King's to collaborate. And whenever there's a resident meeting, anything on vascular and skull base, I'll be more than happy to, sit with you guys and learn.
Thank you, Professor Cherian, for such kind comments and showing us excellent cases with excellent outcomes. If there is any question for Professor Cherian, we can use the chat box now and we'll be happy to answer. If not, then we'll conclude the session because we're nearly at the end of it. I would like to thank you again, sir, for joining us and showing us excellent cases. We will love to have you in future as well. If there's no questions, then I would like to conclude the session. Is there any question from Professor Cherian? I think you have explained it perfectly because there's no questions. Professor Cherian, it was an honor to have you. I would like to conclude, we'd like to end the session here, and we'll see you in the future as well. Thank you, sir, for joining.
You're welcome. Thank you very much.
So guys, I'll see you next week. So there's a question from Dr. Yasser. He's saying he's actually appreciating your the tricks that you shared, and it's basically a comment. And so with the exoscope, do you have issues with depth perception? For example, when when I was getting trained, we had the first of the exoscopes, and there was always issues with depth perception. Do you have the same thing with your exoscope?
No, you know, I remember the Aga Khan had
Yes, yes.
it's a synaptive, right? It was a
Yes,
synaptive, right?
yes, the synaptive one.
Well, it's completely different from Synaptive's exoscope. First problem was it was 2D. They made it 3D, but then they made it like a microscope. It was more like a microscope. So it was standing from your, it was standing from your shoulder, and then it had some fantastic features, but then the AEOS exoscope that these guys have come up with is far better than anything. See, Kinevo is a fantastic microscope, but then, you know, when you are in a sitting position, you should see the exoscope versus the microscope. It is completely a different proposition. And if you're doing a CP angle, supposing you have to look towards the brain stem, and on the microscope, you have to, you have to go lean all the way back and then look towards. Here, after I put the point lock on, the exoscope goes all the way and looking towards me, while I can just sit, watch on the screen and then do it. And whatever point that I have to see, it's such a comfortable ergonomics for me to sit and operate, whether it is a bypass, whether it is anything. And the stereo depth is just out of the world. So the only thing is right now, it is a bit too costly at the moment. But once that has been sorted out, then I guess there's no future for microscopes anymore. I mean, it would be a digital camera, and then plus the possibilities of injecting images is not like in the microscopes. This is a digital image in itself. So you can inject, you can inject much more better VR images. That's what we are working on right now. And then we will have a mixed reality image, and navigation will be out of the window again. So there's a lot of possibilities that we are looking at. Well, I want to share, Giacomo just showed me that we had done a jugular foramen. I'll just share my screen for a second. This is the one, Giacomo?
Yeah.
This one, right? This one, right? Yeah, so we recently did this tumor. This is the jugular foramen lesion. We completely took out the tumor. We went the pre-sigmoid and retrosigmoid. I did the retrosigmoid part, and my ENT partner did the pre-sigmoid part. We took out the tumor, except this part anterior to the. Are you seeing this? Are you seeing it?
Yes, we are.
Yeah. So this is the jugular. I mean, since after I was talking about the ridge and everything, I was very happy that she was talking about all that. So we accept this bit which he was unable to take out because the carotid, C7 carotid was, we didn't want to pull anything blindly from in front of the C7 carotid. That part was left behind, but everything else we could take out, and we could preserve every single nerve, the facial and everything. So I would look for the operative video sometime, and I would be happy to share it with you. So this was the scan. This was the scan of that jugular foramen lesion that I was talking to you about. So thank you very much. Excellent session. I'm also very happy. My regards to Salman. Salman is around?
Yes, I'm around. Yes, Raju, I'm here. No, I'm grateful. It's excellent. I think these anatomy talks, I think we should collaborate together because these talks are brilliant. I learned loads. Like, for me, it was all an amazing experience learning today because this part, I think I never read this anatomy so closely, and there were so many things tricks that I've seen today. So, yeah. And yes, all these talks are available actually on our LNS Neurosurgery YouTube channel. So everything goes on there. So there are about, hundreds and hundreds of anatomy talks over there. With talks from experts like you. So we continue to learn. So we must collaborate. I think Saad and yourself can come up with a plan. Let us know. We'll be happy to expedite.
Yes, absolutely, Salman. Always a pleasure to collaborate with you, brother. So I'm very impressed. Thank you, guys. God bless.
Thank you, Professor Cherian, for your valuable comments and the excellent cases. And we'll definitely collaborate for the future talks. And I'll be emailing you or messaging you in days to come. And okay, guys, we'll see you all next week. Take care of yourself. COVID is on a rise. Thank you all for joining.